Oops. All right, hi everybody. This is Dr. Wong checking in live with you. We are live outside my guest bathroom, and we have a special guest who is starting our session this evening. I'm just gonna put that out there for you. You've seen Evan. I think in honor of this evening's topic, keep going, son.
Okay, sorry.
In honor of this evening's topic, we will focus a little on his posture, position of his wrist. There's his elbow. All right, son, you can fade to silence. All right, so we're just going to set up here. Thank you, son.
Sorry.
All right, no, nice job.
Everybody, just noticing I'm still practicing that song.
Okay, thank you. Okay, you're good. You can go up now. Not that way, Ev. Not that way. Okay, so thank you for joining me. Tonight's topic is actually kind of an interesting topic. And I hope that we'll have a little bit of time just to have a little conversation. This is one of the things I miss the most as we basically do these Facebook Live sessions, is to be able to hear you and your thoughts and hear you speaking. So I'm just going to bring a little light a little closer to me here. That will help. And so our topic for tonight, let me just put on my game face. I'm a 40-year-old patient. I work as a mechanic, and I'm complaining of a lot of pain in the lateral elbow region. I'm spending 50 hours a week wrenching away, and the pain has become worse and worse to the point where I am unable to open a jar. I'm unable to play tennis, and it's causing me a lot of disability and pain. So let's say I'm a 6 or 7 out of 10 pain, particularly when I'm using those muscles. Okay, so this is kind of setting the stage. So we're talking a little bit about the elbow. The elbow doesn't have that many conditions, right? So off the top of your mind, what are some of the potential hypotheses that this condition could be besides the obvious tennis elbow? Okay, so just shoot me some thoughts real quick. What are some other potential sources of lateral elbow pain? So take a minute. Man, I forgot my bell tonight, but let's take a look at what you've got. Lateral elbow pain and patients complaining of severe lateral elbow pain. Any other thoughts about potential differential diagnoses? Right, think about, so what structures are there? What structures are there that could actually reproduce pain in the elbow region? Any thoughts from anybody online? Okay, let me just put out there then, just as we are talking about differential, certainly on the lateral side of the elbow you have your humeroradial joint, right, and your superior radial ulnar joint, right? You have your annular ligament, of which these conditions, certainly like arthritis, could be there. Any other nerve conditions that you guys can think of? Any other nerve entrapments in the lateral elbow region? So right now we're talking about a 40-year-old male mechanic complaining of severe lateral elbow pain, and the problem has been going on for the last 6 months. So any other possible causes of this lateral elbow pain? So far we've talked about some joints. You have lateral collateral ligament problems. Of course, that's typically related to some type of trauma. I would add in perhaps elbow instability, right? Again, most commonly these are related to some type of trauma. any nerve entrapments that you can think of that might actually be related to chronic lateral elbow pain? Any thoughts? Any thoughts out there for the viewers who are watching? Right, think about radial nerve and posterior interosseous nerve entrapments that can occur in that lateral elbow region, radial tunnel region, maybe in the arcade of Frosch, the supinator region. Okay, so consider that there are multiple structures that can be pain generating sources or create weaknesses, right? So that we have to always consider. Now let's focus back on the key pattern. I want you to think about this lateral epicondylalgia patients most commonly are in the age groups. I'm just pulling up a couple of notes here. Are in the age groups of 35 to 54. Okay, so what is it about this age group, do you think, that predisposes them to this type of problem? So I'm just going to put that out there for a second. Why isn't it in the younger people? Why is it in the 35 to 54-year-old group? What is it about their life at this stage of their life that causes them to more likely develop this type of problem? Any thoughts? This is related to lateral epicondylalgia. Any thoughts out there from anybody? What is it about the 35 to 54-year-olds that are more likely to have this elbow pain problem? We know that our tissue resiliences are beginning to change as we age, right? So their tolerance to stresses are changing, and yet they are likely to be, one, in their type of job that is requiring some type of manual labor. I'm just saying most people now are in that age working full-time jobs or more than full-time, and there are certain groups that are higher risk for this problem, and that includes smokers. What does that say about the tissue, right? So something to do about tissue health and tissue changes in our body that create this condition where we are less resilient to the stresses that are placed on our bodies. Okay, so smokers are one of the high risk factor people. The other group are manual workers. Does that make sense? It totally makes sense, because this problem doesn't quite exist without repetitive overuse. Is that fair to say? This is a repetitive overuse problem that may have a tinge of central sensitization. So I'm going to try to stratify, and if you look at a recent, I think this is a 2015 article in JOSPT, this is a review, a commentary about looking at tennis elbow and how one size does not fit all. This is an excellent article. Dr. Vicenzino from Australia has put together and has been a leader in talking about tennis elbow. Him and his team have put together this review article that I think will be very useful as you shape your mind about this pattern. Okay, so two things that we've established so far. One is there's an age group, and this age group is between 35 and 54. Our tissues are changing, and we tend to be doing things repetitively, right? Then we have this group of people who are smokers, who are at higher risk. That says something about our tissues and their resilience. That ties into the age and the age-related changes of our tissues. Manual workers and tennis players. Okay, so interesting. This is part of the pattern of the patient walking in the door who says, I have lateral elbow pain, and it's atraumatic. Think about that, right? A lot of our problems in musculoskeletal conditions are traumatic or atraumatic. And if they're atraumatic, I'm always wondering, is there some type of overuse syndrome related to this? Okay, so we have aging, smoking, overuse. Tennis is a very important, tennis, you know, in our CSM talk at CSM in San Antonio in February, we'll be talking about tennis players. More so related to spine problems, but why is it that they have, why are they at higher risk? Any thoughts out there? Why are tennis players at higher risk for lateral elbow pain? Any thoughts about that? What is it about the sport? It's not an easy question. What is it that racket sport people do all the time? What is it that racket sport people do all the time? Any thoughts out there? If you think about one of the key findings for tennis elbow, okay, from this commentary, the 3 key findings that you need to do when you're doing your evaluation, okay, the key representative signs and symptoms of the patient. 1 is palpation of the lateral epicondyle region. So this is part of your key findings, your physical exam. Palpation of the painful region. 2, pain-free grip strength is diminished, right? Painful gripping. And 3, pain reproduction with resistance of wrist extension or middle finger or index finger extension, right? Which is trying to kind of specifically implicate the ECRB. All right, so think about that as part of your pattern. Now we've painted a picture. Who are the people who tend to walk in the door with this problem? And what are the kinds of signs and symptoms that you're looking for? And you'll see these in the key findings. This is part of the picture. This is not someone complaining of clicking and popping in his elbow. This is not an instability. This is not someone who tries to push up from a chair and says, my elbow wants to give out, right? And had a traumatic mechanism of injury. This is someone complaining that when I grip, when I use my wrist, it is causing me a lot of elbow pain, and and this problem for some reason is getting more and more, progressively more, getting worse. Now, one thing to think about is this group of patients in general tend to get better on their own. Research suggests over 90% of patients typically resolve or get better to a certain extent, but there's still 33% or up to 1/3 of those patients who will have persistent symptoms over a year. So remember we just talked about back pain with cognitive and affective tendencies last week. Something about this problem that's persisting beyond 3 months has got to make you wonder, is this really an overuse injury? I think so, yes, check. Is there tendon pathology? I think so, yes, check. But could there be a contribution of the central sensitization of the central nervous system of the brain to... So, as you're thinking about that, I want you to, so we're going to talk a little bit about manual therapy management, okay? One other thing that I would say, there's usually decreased pain-free grip strength. This is an important part of your assessment. And there's also a propensity for when people grip, that they tend to grip with excessive wrist flexion. Now, what could that be doing? Why do you think? All right, sorry about that. I think we are back on live. I have to make sure that the kids are not watching the Octonauts. So yes, Octonauts versus clinical pattern recognition or play that pattern live. It's a tough battle. Now, I think we're back on live. If any of you are hearing me, could you just make a quick reply? Yes, I can hear you, just so I can know we're connected here. Would you just connect us and let me see that you guys are still there? Is there anybody who can just write yes and send me a note? Okay, so let me just move forward. So we've talked about the key findings, right? A few other key things that I think as movement specialists we always have to look at is posture, the types of activities that they do, and the particular movements and postures in which they do these activities. Right, so the mechanic, I remember the mechanic patient that I saw who had multiple debridements to the lateral epi, the tissues in that area. I remember him talking about how hard it was many times to be hunched over into the car trying to get things off of the car and how much gripping that he had to do, okay? So sometimes, inevitably, the person's occupation ends up causing a lot of these dysfunctions, right? It's partly the overuse and partly the age. Was he in his mid-30s? He was in his late 30s, actually, closer to his 40s, right? All right, so key things to assess: local elbow, local accessory mobility of tissues, radial nerve sensitivity, right? Because we agreed that nervous tissue run in that area, and looking at the cervical spine and looking at movement analysis and postures, okay? So some of the key things in your physical exam that we cannot ignore, and though this was not mentioned much in the commentary, let me begin to suggest that there is pretty good evidence that we should be looking at the scapular muscles and scapular positions related to this condition. All right, Dr. Young, part of the team, has already published the management of lateral epicondylalgia in a case study where they just strengthened mid traps and low traps. That's all they did. And the patient's symptoms began to get better. So think about that. And what does that mean in the management of this overall problem? All right, so I'm going to give myself 5 more minutes to tie up these loose ends, okay? Let's talk a little bit about management. The commentary, all right, sorry about that, everybody. All right, so about is when you are thinking about managing this lateral epicondylalgia problem, I think it's very valuable to think of it in as different stages of the tendon problem. In one stage, it can be at a very reactive stage. There was a recent overuse. There may be inflammation or maybe not, okay? In those particular cases, these patients, you should not be doing things that induce more. All right, sorry about that, everybody. So, in the early acute reactive stage, in that particular situation, you're going to do things, especially if the patient is stressed, in a lot of pain. It's okay to use multimodal management, meaning the doctors can prescribe antidepressants. You can use positive words of recovery, meaning help them understand that this is an overuse problem, and many people will continue to get better, right? It sounds a lot like low back pain and neck pain, right? You can go in there and use gentle isometrics, because isometrics we're beginning to find is a way that you can modulate pain, right? So we don't want to, in this type of highly irritable group, you don't necessarily want to be doing your hard manual therapy, your eccentric exercises where you can wind the patient up with more and more central sensitization, with more and more pain, right? Wind up their brain more. Because these patients who have higher baseline pain, higher levels of disability when you see them, these people need a little tender love and care, okay? A little bit of positive energy, positive reinforcement, positive education, and they just need to know to rest a little bit. Now, as you move forward, as the patient moves out of that acute reactive stage, then your use of the eccentric type exercises, right? You could have the patient holding a dumbbell, use his other hand to pull the dumbbell up and then slowly lower it down, right? And using the same principles of muscle power deficits for the Achilles guidelines, for the Achilles tendon conditions like muscle power deficits, which this would be considered muscle power deficit, we would use in the subacute and more chronic tendinopathy conditions, we would use these eccentric exercises to potentially stimulate healing and reorganization, right, of the collagen. And we know that this problem, the tennis elbow problem, does have some collagen issues. So when you notice, okay, one key pearl I think that will be useful for you is you always take pain-free grip strength. And you also should be palpating the epicondyle region. If you find that their pain-free grip strength is extremely low, meaning they're very disabled, right? They're very weak because of the pain, and their pain pressure palpation, or if you use an algometer, their pain pressure threshold is very low. So that their disability of strength, their functional limitation of strength or impairment of strength loss matches their pain sensitivity, right? High pain sensitivity. All right, guys, sorry about that. We're just finishing up here. In the highly irritable patients, basic isometrics, if there is a matching, right? Matching weakness, grip strength weakness, and their pain pressure threshold or their sensitivity to your palpation is matching, meaning highly irritable, then you might consider treating away from the local tissue. I would not scrape this tissue. I would give them positive education and then treat at the cervical spine region, cervical thoracic spine region. Manual therapy to the cervical spine region, because we know the manual therapy techniques there can modulate the pain down. On a therapeutic exercise perspective, I would be using isometrics, gentle isometrics to the wrist extensor region, okay? As the patients begin to transition from this acute reactive stage to more of the chronic tendinopathy, lateral epicondylalgia, non-inflammatory condition, then you can progress to using your manual therapy in the sense of local tissue, where you could be doing strengthening and eccentric training. Okay, so from your concept of first observing the patient and ensuring that you recognize this pattern of who's walking in the door, I think it's important to stage the patient. Are they acute inflammatory reactive, or are they more chronic tendinopathy driven? And so you would manage them slightly different. A couple of other things that I just want to say is, remember that there's emerging evidence of scapular weakness of the muscles, and managing those muscles, I think, are relevant. Okay, so consider that as, hey, if you can't do stuff around his elbow because he's too irritable, maybe we should start with just strengthening the base of stability, right, around the scapular region. And the other thing too is, when people are doing gripping, we are worried when we see people who grip with too much flexion, and I'm also worried when I see people grip with too much extension. Okay, so I want to train people to grip with their wrist in neutral. So think about how the movement and correction of movement, do less gripping of heavy things with your forearm pronated, right? Because that requires a lot more extensor activity. Do it more with the forearm supinated. Okay, so with those things in mind, I just want to say, think about tennis elbow not just as a... Think of this tennis elbow problem as not just a local tissue problem. There are signs of central sensitization. I also believe that the evidence will continue to emerge that our management of this patient from a movement perspective, how are they lined up in space, right? Their postures, the strength of their muscles, right? The strength of their muscles in their scapular region, how they use their wrists and hands. All of those are players, and that you can stratify your treatment from highly irritable to more chronic tendinopathy. You have to be able to stage the patient that way. So I think I'm just going to finish there. Thank you for joining me. I know this is a vacation weekend, but I'm glad to have spent the time with you talking a little bit about tennis elbow. This is not just a musculoskeletal problem. I think we can all agree, and the evidence is pointing to that there are regional deficits. There are central sensitization components in which we would consider managing these patients that way. Just as a heads up, all of these things that we have just talked about here are also we finally released the elbow, wrist, and hand, those two apps. These concepts are built straight into the key findings, the exam, the treatment of tennis elbow. I think we're going to take a couple weeks off. I think everybody just needs some time to just enjoy being with family. I'm thankful for each of you. I am excited for you as you continue to shape and clarify in your mind how we manage these common musculoskeletal problems. And I hope you guys have a wonderful and Merry Christmas. Enjoy time with your family. We are going to be going, for the boys' Christmas presents, all three of them got slingshots. And so we are going to wander our way into the forest to play with slingshots. Here's potentially the last time you'll see. So just saying, Merry Christmas to you, and looking forward to catching up with you guys in the new year. Hope you guys have a wonderful time. Take care and have a good night.